And with all the new waves happening, a lot of people were under a lot of pressure, but we are so glad to see all of you here. We want to welcome all of you. Just some housekeeping rules. If we can ask everybody to just keep their microphones and their videos off. And then if you do have a question, just put it in the question and answer box and we will answer as we go along. And at the end of the presentation, there will also be time to address them live. So if we can just please keep to that. Then as well, there is going to be Portuguese and Arabic interpretation simultaneously while we are on this call. And we will ask people to just keep to a slower pace talking, just allow them to be able to interpret it as well. And then there will be tomorrow, there will be the French session on the same topic during the normal slot that we have every Thursday. And Prof. Azus will be running that French session tomorrow. So just to say to you that for the next 6 weeks, we will be discussing moving forward as we've done since last year, and then we will have a 1 week break before we carry on with the next series. So if you do have any specific topics that you think you want us to address, please send us an email and we can see how we can address that or put it in the chat or the question and answer box. So for me, I just want to hand over to Dr. Wahid Aryo Bakari from Africa CDC to give us the introduction on the COVID status of Africa. Thank you, Dr. Aryo.
Okay, good afternoon, colleagues. My name is Chika Okenedo, so I will be filling in for Dr. Aryo. He's on leave, so I'll have to share my screen for me to take you through the epidemiological situation. Please, just to confirm if you are able to see my screen.
Yes, we can see your screen. Thank you. Can you make it maybe show? Then we will be able to see.
Yeah, it's taking a little time.
Thank you.
Okay. Yeah, thank you so much. So moving on, I will take you through the epidemiological situation as of 21 July 2021. So here is the global epidemiological situation of COVID-19 update. On the left shows the planet map of affected countries, and therefore the chart on the left shows you the distribution of latest cases in the week by 6 geographic regions. Each color represents the region on the legend, and the bulk of those cases are being reported from America, European, Southeastern Asia, and Africa within the red bar accounts for 3% of the worldwide cases and 4% of deaths. Overall, the planet has recorded over 190 million confirmed cases of COVID-19, of which over 4 million have died, with a case fatality rate of 2.2%. So this slide illustrates the epidemiological situation of COVID-19 in Africa as of today, 21 July 2021. Should I move ahead? There's an interference.
Yes, I see this in somebody else as well. If we can just ask them to switch off their video and microphone as well. Thank you. Please go ahead. You are muted at the moment. Can you carry on? Chibu, can you hear us? Can you carry on?
I was muted. I don't know how come. Okay, can you hear me now?
Yes, I can hear you.
Okay, so like I was saying, that The epic curve on the right is showing the new COVID-19 cases reported daily by regions. And the red line represents the 7 days moving average that shows the continuous reported cases in 55 member states. The Africa figures indicates over 6.2 million cases, over 159,000 deaths, leading to a case fatality rate of 2.5%, and over 5.5 million recoveries, of which 87% people have recovered from COVID-19 across the continent. However, the cases reported are on a downward trend for this week, but over 280,000 new cases were reported this last Epi week. Okay, so this table is displaying the distribution of COVID-19 cases, deaths, and recoveries by AU regions. As of 9 a.m. today, for Epi week 28, over 270,000 new cases, about 5,000 deaths, about 6,000 deaths, and over 240,000 recoveries reported from the member states within the past week. And the majority of these new cases were reported from the southern and the northern region. So this Epi week, southern region reported this Epi week reported the most of the number of new deaths and new recoveries. South Africa, Tunisia, Libya, Botswana, Mozambique, and Morocco accounted for 74% of the new cases, and South Africa alone accounted for 36% on the continent. So moving on to the incidence per 1 million per day by AU member states. This week we classified the incidence into 5 categories with the new cutoff points to match that of the COVID-19 tiered public health and social measures framework for Africa. So in the past Epi week, which is 28, which is 24 countries reported less than 5 cases per 1 million population, 9 countries 5 to less than 20 cases per 1 million per day, and 10 countries reported 20 to less than 80 cases per 1 million per day, and 9 countries reported above 80 cases per 1 million per day. So, so this slide is showing the case fatality rate by AU member states. And also we can see it is being categorized in 5 different categories. 11 countries have a CFR that is reporting less than 1%. 22 countries are reporting within 1 to 2.2%. 17 countries or member states are reporting above 2.2 to 5%. That is, it's higher than the countries reporting CFRs that is higher than the global CFR, and then 4 member states reporting over 5% case fatality rate. So with regards to testing, this graph illustrates the cumulative testing conducted altogether at the AU member states by region. Over 56 million tests are conducted across the continent, with 9.1 tests per reported cases. The general positivity rate is 11%, and therefore you can see that the brown and the red bars represent new tests and new cases respectively. The black moving line is the percentage positive. Currently, it's on a downward movement for week 28. So observing the test positivity rate by AU member states for the past epidemiological week. This week we classified the test positivity into 5 categories also. And 15 countries or 15 member states have test positivity less than 3%. 4 countries have test positivity between 3 to less than 5%. And 9 countries or member states reporting test positivity from 5 within 5 to less than 12%. And 14 member states reporting test positivity above 12%. So I think that's all from. Thank you for your attention, and over to you, Doctor.
Thank you very much, Chipo. Thank you. This is great to see, and we are glad to see the curve is coming down. So I want everybody to just be safe. Just before I hand over to Dr. Neola Williams from DRASA, I just want to also mention that we will follow the same rules that if you attend at least 4 out of the 6 sessions and you also stay on for about an hour, you will be able to get a certificate that Susan will send through. So when you do register, make sure you give us all your information that we needed to put on the certificates. So I want to now hand over to Dr. Neola Williams, which is the Managing Director of DRASA, and she's been on one of our previous ones again. So I'm going to hand over to you, Dr. Neola, to take us through the rapid response team, the role of the IPC professional. Thank you.
Thank you, and good morning to everyone. I'll just share my screen. Okay, great. Good morning, everyone. My name is Neola Williams, and I'm the Managing Director of DRASA, Dr. Ameyo Stella Adadevo Health Trust. But in this presentation today, I'm going to speak about the role of IPC in rapid response teams. And I'm going to use specific examples from my experience as a member of the rapid response team for COVID-19 here in Lagos State in Nigeria. So the objectives of this presentation, we'll talk about what a rapid response team is. We'll also talk about the role of IPC in outbreak response. And then we'll talk about how IPC plays a role in outbreak response beyond the health sector. So what is a rapid response team? Before we define this, I would just like to see from the participants, can you raise your hand if you have played a role or been part of a rapid response team in your country for any particular emergency or outbreak? Can I just see some hands raised, please? We'll drop the hands afterwards, but I would just like to see how many people have been part of a rapid response team, maybe for COVID-19 or any other outbreak. Okay, great. I can see we have quite a few people. Fantastic. Okay, great. Thank you very much. We have about 23 people that raised their hands. Okay, so what is a rapid response team? A rapid response team is a very important part of outbreak response. But before I talk about the team and who makes up the team and how the team functions, I want to give us a foundation of how these teams work. A rapid response team is a group of individuals that are in charge of the groundwork when it comes to responding and controlling outbreaks. However, they fall into a framework called IMS, which is the Incident Management System. And this is like a very standardized approach to respond to and prepare for emergencies. And the IMS is implemented through a Public Health Emergency Operations Center, PHEOC. So I know this is a lot of acronyms and you know, a lot of vocabulary I'm giving you. So we will go through each one by one. So let's start with the Incident Management System. Like I said, the Incident Management System is a structure that is used for emergencies. Now, I want us to note that this structure is used for emergencies that are not limited to public health. This is for something that is used for, you know, fires, different kinds of emergencies across different sectors. But for the purpose of this lecture today, we'll be speaking about how this works for public health and specifically specifically for outbreak response. But it's a standardized approach to preparing for and responding to emergencies, and it can be scaled. It can be implemented at a local level, at a state or a district or a province. It can be implemented at a national level. It can also be implemented at a regional level. And the IMS structure is implemented in a physical space called a Public Health Emergency Operations Center. So you can see here on the right side of the screen, you have the IMS system, but then the PHEOC, which I'll show you some pictures of what that looks like later, is the home or the house for this system, this emergency response system. So this is a sample of what an incident management system looks like. You have an incident manager who is the individual person that is in charge of the overall management. So if there's an outbreak of, let's say, Lassa fever, there's one person that's in charge of responding to that outbreak in that particular location, and that person is the incident manager. But that person is supported by many other functions. So you can see communication, finance and admin, logistics, planning. But for our purposes today, because we're still talking about rapid response teams, we're going to focus on the operations function, which you can see circled here in yellow, because this is where the operations, this operations function is where the rapid response team belongs. That's where the rapid response team sits in this overall system. So you can see there we have our rapid response team members as part of the operations part of the incident management system. So what does that mean? The Public Health Operations Center is a physical space, and that's where everything is coordinated. I'm sure you can imagine, and some of you obviously have experience that during an outbreak, it can be very hectic. There will be people with different functions doing different things. And so you need a physical space where everything can be coordinated to ensure there's collaboration amongst all the stakeholders, to ensure that communication is strong, to ensure that logistics and materials and resources are deployed properly to respond to the outbreak. We have, resource management issues where we need to ensure that we're deploying the right human resources as well as supplies and materials that are needed. And so this particular center, this place, this physical space is where all of the outbreak response and investigation activities come out from. And then it's also where the recovery process comes in. So after the outbreak is over, there's a process of recovering from the outbreak and learning from what happened. And that is also conducted within this physical space. Now, these are some examples of public health emergency operations centers that I've been in here in Nigeria. So I just took some pictures and I'm sharing them with you, but you can see that it's not anything very complicated. Most of the time, it's just something that looks a bit like a conference room where you have different partners and agencies represented, different stakeholders coming together as part of the public health emergency or outbreak response. So let's go into the rapid response team. Like I said, the rapid response team forms the operations team for an outbreak response. And they provide support. So you can think of the rapid response team as almost like surge staff. So when there's an outbreak and perhaps the location where that outbreak is occurring, they don't have the right skills and qualifications to respond, then they can bring in extra people to come and support the local health authorities in managing the outbreak. The goal of the rapid response team is to fill any gaps that the response may have, but these are people that are already trained, already equipped, they already know what to do, and they're ready to deploy. Now, in severe situations like with COVID-19, we had to actually train and equip a lot of members to join the rapid response team. But in an ideal situation, these are people that would already be on standby, ready to respond. That's why they're called a rapid response team. So who makes up this team? Who are the members of the rapid response team? So it's actually very flexible, and it often depends on the nature of the response and the expertise on ground and the gaps that need to be filled. But essentially, in every outbreak, in every situation, the rapid response team is multidisciplinary. You have people with different skill sets and very different backgrounds coming together to respond to and control an outbreak, because we know how complex outbreak management can be. I'm sure many of us have had experience with that, even just during COVID. Now, this, again, is the structure of the rapid response team within the incident management system. But I want to take us to the role of IPC in outbreak response, because that's really what we're here to discuss today. Now, overall, this is what a rapid response team can look like as forming the operations part of the public health response. You have your case management person or team. Now, I want to mention that each thing on the screen right now, we call them pillars. They're like teams, or in some cases, depending on the size of the outbreak, they may just be one individual. But these are different types of expertise that contribute to the overall rapid response and emergency management structure. So you have your case management team or individual, and that pillar is really involved in managing patients, taking care of cases, and tracking recoveries and deaths. Then you have your epidemiology and surveillance team. They do active case search, and they're involved in different activities, as I'm sure we know, depending on which phase of the outbreak you're in. Then you have IPC, which I will go into in more detail in the coming slides. Then you have the lab team. Of course, we have to have specimens collected and tested. We have our risk communication, social mobilization, which look at facing the general public, engaging communities, engaging leaders, engaging people on what is happening and communicating with them. And then we have other specialized structures and pillars like points of entry, which I will go into a bit later. So again, for the purpose of this lecture, we're focused on the infection prevention and control pillar and the role that we play as IPC professionals in a rapid response team. So the main mandate or goal of IPC as part of the rapid response team is to prevent and minimize person-to-person transmission during outbreak response. So you can see our very common chain of infection. I'm sure we're all familiar with the chain of infection that's on the right side of the screen. The goal of this is to break the chain. That is what IPC is all about. And so some of the specific roles of what IPC people or professionals will do as part of a response team are listed here. This is not a complete listing, and I'll show you some examples of other things that happen later, but these are just 5 things that I'm choosing to highlight because of the time constraints we have for this lecture. So the specific roles include training, developing and disseminating SOPs, guidelines, and tools, conducting risk assessments, auditing and monitoring IPC practice, and then managing and looking at infections and exposures. So I'll go through each one of these one by one now. Training. So training was a big part of the rapid response team for COVID-19 across the continent. We know that our partners and our hosts, ICAN and Africa CDC, were huge parts of this for COVID-19. And thousands of health workers around the continent have been trained on infection prevention and control. However, this training has been limited to more of a frontline health worker training, not a complete IPC training. We focused on, things like standard precautions, transmission-based precautions, because of the nature of the emergency. And so IPC professionals play a huge role in building the capacity of everyone involved in the rapid response team. And I want to give some concrete examples. Training people in the response. Remember, we said in a previous slide, I just want to go back, the response team is varied. So you have to train those that are at the points of entry. That's the airports, the land borders, the seaports. You have to train those that are doing the case management. Those are the health workers, both clinical and non-clinical, working in the isolation centers or in the areas where the infected patients are. You have to train those going out to do active case search and tracing infections. You have to train those in the lab. You have to train those in driving ambulances that are maybe transporting sick patients. You have to train so many different cadres and groups of people need to be trained. So everyone involved in the response needs to be trained on infection prevention and control. And then, of course, we know we have the clinical health workers, those treating patients. We have the non-clinical health workers. We have those in public or government facilities. We have those in private health facilities. So there's a lot of training and capacity building that has to be done. These are just some pictures of the trainings that we were involved in. You can see we trained cleaners, we trained specimen collectors, we trained ambulance drivers. Of course, we trained doctors, nurses, cleaners, porters, everyone involved in the response. Even those that were working in the Public Health Emergency Operations Center as, the finance and admin team, they also had to be trained because they were exposed to people who were going out on the field and doing the work. And so there was a lot of training that needed to be done across different roles and responsibilities. The second role of IPC and the Rapid Response Team is SOPs and guidelines and tools. Now we know that, using COVID-19 as an example, there were a lot of SOPs that were developed by international bodies, Africa CDC, and of course WHO, US CDC, ICAN. We had so many different people developing and having all these great tools. But the role of IPC is to get those tools and disseminate them and domesticate them for the local response that was happening at the time. And these tools cover different things, from triage, how do you triage, how do you do standard precautions, how do you collect samples, how do you do safe burial, how do you transport patients, and any other special needs. We had situations here in Nigeria where we had special events that needed to take place in the middle of the pandemic, and we needed to come up with guidelines and SOPs on how those events would go forward. You had countries that had to conduct elections during the pandemic, and there's an IPC component of that. How do you conduct an election in a safe manner? How do you manage exposures? So there are a lot of different guidelines and tools that need to be developed by the IPC professionals that are part of the Rapid Response Team. Another component of the role of IPC in responding to outbreaks is doing risk assessments, which is a huge and core foundational part of IPC. When you look at the ability to evaluate a space, is this space prepared to admit sick patients? Is this space prepared to hold people for 14 days for the incubation period of this particular pathogen? When you look at all that happened during COVID-19, risk assessment was a huge part of what needed to be done. And in many cases, it was done by the IPC professionals that were parts of the Rapid Response Team. So here you can see some pictures of the work that we did. While we are not construction or builders, we don't build buildings, but of course, risk assessment also has to do with looking at a physical space and seeing how good is this space to do the work that needs to be done in a manner that will not encourage the transmission of whichever pathogen you're responding to. So we did risk assessments to look at private hospitals, public government hospitals, isolation centers, quarantine and holding centers, places where they were collecting samples. And I just want to highlight this picture here in the middle. I hope you can see my mouse where I'm circling. This was an innovation that we contributed to here in Lagos State, where there was a group that was setting up an isolation center, and they wanted to also have a specimen collection for COVID-19. And this is a very great IPC innovation where you have the patient will be on one side of the glass and the sample or specimen collector will be on the other side. And they put their hands through these two holes here to collect the specimen from the patient. That way it minimizes contact between the specimen collector or the lab personnel and the possibly infected patient. So these are the kind of, IPC innovations and things that we had to look at as part of the Rapid Response Team. How do you set up, a patient bed area or an ICU, even holding areas? We had to go and do risk assessments in hotels that were going to be converted into quarantine and holding centers for people traveling into the country. So the idea of all of this is to look at these spaces, both normal, hospitals and health facilities and wards, as well as all these other spaces that needed to be created as part of the response to identify IPC gaps and think through innovations and interventions that could be put in place to make these spaces safer. And again, to go back to our mandate, which is to minimize and prevent person-to-person transmission during the outbreak response. Another interesting point I want to make is we also had to do this for ambulances. We had ambulances that were carrying patients from the community into, a ward for COVID-19, and we had to look at the structure of those ambulances, the airflow, and advise on how even the drivers and the health personnel in those ambulances could protect themselves while they're transporting sick patients. So risk assessment is done in multiple settings, not just physical buildings or isolation centers. It's also done, in other areas of the response. The fourth role that I'm highlighting of the IPC professionals in a rapid response team is auditing and monitoring. So supervising operations. You have a hospital that is taking care of COVID-19 patients as an example. That hospital and the operations and the functions that are happening need to be monitored from an IPC point of view. Do they have an IPC focal person working there? Does that person have the tools they need to monitor what's going on in the facility, to measure compliance with things like hand hygiene, donning and doffing, and all the standard precautions and transmission-based precautions? So supporting those activities, that monitoring is very important because it helps in identifying gaps, identifying challenges, and being able to respond to them quickly. And then the fifth role that I want to highlight is managing or tracking infections and exposure management. We know that thousands of health workers have been infected in the COVID-19 pandemic as part of the response to the pandemic. And so identifying those health workers and trying to look at the data to identify the reasons behind these infections. Why are health workers getting infected? Is it a breach in IPC protocol? Is it because they don't have PPE? Is it because they're not trained? What are the reasons that they are getting infected, and what can we do to mitigate that, to reduce the numbers of infections among members of the rapid response team or members of the outbreak response? And then also supporting exposure management. So you have, a hospital that has been, in the early days of COVID, we had hospitals where large numbers of the staff of those hospitals were coming down with the infection. And how do you manage the exposure? Do people continue work until they start developing signs and symptoms after they've been exposed? Does everyone go home and the hospital shuts down? All of these different kinds of things around exposure management need to be considered. And it's really the role of the IPC professionals to come up with the guidance and professional experts, contribute their professional expertise to solving some of these challenges. So those are the 5 roles that I've highlighted for IPC as part of the rapid response team. And though IPC is generally done as a standalone team or group within the rapid response team, I want to argue that, in fact, IPC cuts across every aspect of the rapid response. IPC, as an IPC professional, you will have to work with the case management team because they are the ones that are actually going and dealing with the patients. They're treating patients, they're managing patients. And so there's a huge IPC component there because they have to be practicing IPC sufficiently to reduce and minimize the spread of the pathogen beyond the areas where they're working. For EPID and surveillance, of course, we know the same thing. IPC is huge when it comes to active case search, when it comes to going into the community and responding to outbreaks in non-healthcare settings, which I'll speak to in the coming slides. Then, of course, the IPC team has the mandate that we've gone through, the 5 roles that I highlighted, for example. But IPC also has to work with the lab team. You can see that they need to be trained on IPC, specimen collectors, those working in the lab. There's an IPC component of managing even just the samples that are being collected, transporting them. The people, in Nigeria here, we had a lot of specimens transported on bikes. And so they needed to be trained just on transporting the specimen. Then risk communications is another team that the IPC professionals have to work with because risk communications is public facing. So they work beyond the health sector, right? They work in communities, schools, places of worship. They have the mandate to educate and communicate about the outbreak to members of the community. And there's a huge IPC component there because we've had incidences where risk communications has to come to IPC and say, okay, what do we tell people? How should they wear their mask? How should they wash their hands? How do we translate the science of IPC to something that the general layperson, in a community can understand and practice? Because IPC was being practiced in communities and still is during COVID. It's a matter of working together. And I think that's the biggest thing I want to come out of this lecture is that IPC, yes, as IPC professionals, there are specific roles and responsibilities that are required as part of the rapid response team. But IPC actually cuts across every aspect of the response. And it's very important to collaborate with other members of the team for IPC to work properly. Now, I want to talk beyond the health sector. Like most of the things I've been talking about now have been within the health sector, within health facilities, isolation centers, and things like that. But IPC plays a role in other areas. And so I'm going to highlight just a few, and I'm going to start with points of entry. So what is a point of entry? A point of entry is a land border, a seaport, an airport. You know, you may call it ground crossing, but it's a place where people travel in and out of the country. And there's something called global health security, which I won't talk much about, but the essence of health security is that we live in a very globalized world, and COVID-19 has shown us how fast microorganisms and pathogens can spread. And so every country's points of entry are now possible entry points for the beginning of what could be an outbreak or a pandemic. Here in Nigeria, we have our port health services, who are our health workers, our doctors, our nurses, our medical officers. They work at these places, these vulnerable points into our country, the land borders, the seaports, and the airports. And you can see that these places are significant because just last week, we had a case of monkeypox that was imported, as you can see, the headline says, into the US from Nigeria. A person traveled from Nigeria to Texas, and he unfortunately had monkeypox. And so you can see the importance of IPC at points of entry, because you may or may not know whether passengers, whether cargo is infected as it comes in and out of the country. We know that with Ebola, there was cross-border contamination or cross-border transmission. And of course, with COVID-19, as early as the 14th of January 2020, we had cases outside China. So what are we looking at? These are some examples of some of the work that my organization has done at different points of entry here in Nigeria, at airports, at seaports and land borders, looking at how do we prepare for and identify and contain these infections in passengers, in cargo, and then even among the staff, because these points of entry have large amounts of staff. You have immigration officers, you have customs, you have the airlines, you have the ship owners, you have the ground transport, companies. You have so many different stakeholders moving in and out. The volume of people and cargo moving in and out of these places every day in any given country is a lot. And so how do you do IPC properly? How do you ensure that if anybody in any one of these points of entry is infected, they don't infect everybody else? So IPC has a big role to play at points of entry. IPC also has, and just to follow on with this, during COVID-19, we did a bit of work with ICAN on airlines, and how do we restart our domestic flights, for example, when we're in the middle of a pandemic. It was very important to look at screening, identification of infected passengers, and then managing any possible exposures. And I want to give a personal example of this. I traveled out of Nigeria a few months ago, and I was on an international flight. And when I landed in the destination, I had to quarantine for 10 days. For 5 days. And I came out on day 6 after testing negative. And then I received a call from the public health authority in that country saying that someone on my flight tested positive. And so I have to go back into quarantine for an additional 5 days, which I did. So, these are some of the new guidelines and the new way of life. And it really still boils down to IPC, infection control. Quarantine, all these different strategies that we're using outside of the health sector are still at the core IPC strategies. These are some examples of training that we did for cabin crew and flight personnel as they were resuming operations in the middle of the pandemic last year. Schools are another very interesting non-health sector, I guess you can say, place where IPC needs to be practiced. And we've done a lot of work here in Nigeria with IPC in schools. We're still doing work with schools as we speak. We still have schools that are having outbreaks, not just primary schools or secondary schools, but even universities. And so there's a lot to consider there, where you look at infected students or staff, the proximity they have with each other, the amount of time they spend with each other, the amount of contact they have, some of the IPC considerations. Apart from the standard precautions and transmission-based precautions, you have things like, having an emergency plan, making sure the students are not sitting face to face. Of course, we know the basic things, standard precautions hand hygiene, universal masking, ventilation and placement, and of course, educating. Educating is one of the biggest things when you're looking beyond the health sector, making sure that people, wherever they are, whether it's in the airport, whether it's in a school, they're educated and they understand the virus and what their role is in preventing transmission of the virus. Places of worship are another very interesting area that IPC can play a role. You have issues surrounding space, ventilation, sharing of items, singing, praying. If we're talking about, respiratory viruses like COVID-19, these are all big concerns. And again, the people that are attending these places of worship need to be educated, and these places of worship need to have some kind of a plan of what to do in case of emergency. These are just some examples of, things we suggested in terms of spacing, of course, physical distancing, reducing the duration of the services and the activities happening in these places of worship. Offices and retail outlets are another place where we've seen outbreaks happen. We've had outbreaks happen where an entire office of staff are infected, especially when they have an open office plan. We have retail outlets, things like banking halls, shops and stores, where IPC has to be a consideration. Oftentimes in these spaces, you see screening, temperature screening, though we know that there are mixed reviews on how effective that is. Minimizing crowds, ensuring social distancing or physical distancing, and managing exposures as well. This is one very unique example that we saw here in Nigeria in the early days of the pandemic last year. I believe this was taken just after we lifted our lockdown here in Nigeria. You can see this is a pharmacy, so people were going to seek to get products from the pharmacy. And the pharmacy, before they reopened, they painted on the ground outside squares so that people would stand there and be attended to one by one while having other precautions in place like, universal masking and hand hygiene. So in conclusion, I want to just, again, the main lesson from this lecture is that IPC cuts across the emergency response. Though there are specific things that IPC does, IPC professionals do in a response, it's very important to remember that IPC plays a role in every single pillar. And also we should remember that IPC, while it has a huge role to play in emergency response, it's not supposed to be only used during emergency response. As we still respond to COVID-19, as we still deal with the pandemic, we need to look at ways to embed IPC in our health systems across the continent so that it's not a matter of, Ebola comes and we do IPC and Ebola goes. Monkeypox comes, we do IPC and then it goes. IPC should be part of our everyday operations in the health systems across the continent so that we don't have to invest as much time, resources, and capacity building to get IPC where it needs to be when these emergencies happen. And I'll just end with a quote that says, "Coming together is a beginning, staying together is progress, and working together is success." And this is just to remind us again that IPC is everybody's business. As IPC professionals, we need to work together with colleagues from different parts of the health sector. And again, like we've seen, even beyond the health sector, to break the chain of transmission whenever and wherever an outbreak occurs. Thank you very much.
Thank you very much, Dr. Nyola. We will address the questions and answers just now. I know that the interpreters ask us just for a few minutes to just raise their voices. If we can just give them 1 or 2 minutes, and then we can move forward with the questions and answers. I see a lot of people ask for presentations, but we will touch on that just now. So we will just give the interpreters 2 or 3 minutes just to take a breather. Thank you.
Thank you.
Okay, I think we can start now. I'm going to hand over to Dr. Wande to take us through the questions and answers. Thank you, Dr. Wande.
Thank you very much, and good afternoon, good morning, colleagues, depending on where you're joining us from. Thank you very much, Ninela, for that fantastic presentation. I think it was quite insightful, particularly how you moved from what IPC experts should be doing in healthcare settings and non-healthcare settings. We have quite a bunch of questions for you, but I know that I have other experts from ICAN, from Africa CDC, who will be available to support some of the discussions. So no worries. I will make sure that I give you some time to catch your breath, then circle back to you. Colleagues, please keep your questions coming. I think we will have an interesting Q&A discussion today. So I think one of the things that has been flagged, which I'm also happy to touch a bit on, is that the pillars which you presented did not include logistics and supply chain. And this person has asked that, is it possible for the IMS to function properly without the logistics aspect? So I'm happy to hand over to you and also touch a bit on it if you would like.
Okay, great. Thank you. Thank you, Dr. Wande. And good afternoon to everyone again. I just want to go back to this slide. So when there were two different graphs, or I don't know what to call these charts that I shared, this particular one shows the IMS as a whole, almost like a high level zoom out view. And you can see that logistics is a huge part. Definitely the IMS cannot function without a planning team, a logistics function, an admin and finance function, as well as an external liaison and communications function. But for the purpose of this lecture, I was focused on zooming in on this operations function, which is really the rapid response team. And so when you look at the operations function, which again is the rapid response team, I want to go to that slide. These are the functions within the operations function. These are the functions of the rapid response team. So logistics is not here at this zoom in level, but logistics is in this zoomed out level here. So I hope that answers the question.
Very well said. I think I hope that answers your question. Indeed, logistics and supply chain is really critical to the IMS, and Ninela has already shown that. So I have two questions popping up, which they're quite similar. I know that I did see like references in your slides, and to participants, all of the slides will be made available to you, and you can always go back to cross-referencing them. So the question is around how can we get guidelines, SOPs for rapid response teams, and will the SOPs be shared? I know that Anna, as well as other colleagues, will try to put links of websites on the chat, but if you'd like to also direct some of our colleagues to websites or references that you used, I think that's very well.
Yeah, so for us, we basically followed guidance from Nigeria Center for Disease Control as well as Africa Center for Disease Control. We also adopted some things from ICAN as well. And the goal was that we wanted to use, things that were being disseminated across the continent and then now domesticate them or contextualize them for our setting that we were responding to. So what I would recommend is looking at those websites. You have the Africa CDC, you have the ICAN website. WHO has a lot of things as well. And looking at those things, and if you have your own public health institute in your country that is also disseminating, make sure you're getting those locally adapted, is the word, guidelines and SOPs, because it's very important to take what is there and make sure that it can apply to the setting where you find yourself. So it's difficult to share with you exactly what we used because it probably will not apply in your own setting.
Lovely. Thank you very much. I will let you catch your breath. Professor Shade, if you are on the call, I see you. I think I'll direct this question at you, mainly because of the work that ICAN is already doing around trainings, and of course in collaboration with Africa CDC, is how often should staff and healthcare workers in healthcare facilities have IPC trainings done? That is the question. How often should it be something that we do every year? every 2 years, just a one-off training. So I think it will be helpful for our colleagues to know that, I mean, the relevance of this webinars that we are running, virtual trainings that we are running, and how relevant it is to their content. So over to you, Prof.
Okay, thank you very much. I think I'll answer it in a sort of broad sense. I think every time a staff joins a facility, they should have IPC training when they join, a sort of orientation, which takes them through IPC in addition to whatever they're doing within the facility, their policies and so on, but standard precautions, transmission-based precautions, and anything relevant to the facility at that level. And then at a minimum, they should have annual training to remind them, because we know that human beings do forget and human beings can stray. In addition, when you have a focal person, they should take an opportunity at every point when you're monitoring adherence to give feedback immediately. So somebody's doing something wrong in a non-judgmental way, you support them to do it properly. You tell them what they haven't done well and how to do it better. And if possible, show them how to do it better. So as a minimum, annually, there should be a sort of mandatory training for all staff that they should sign off that they have had their IPC training, almost like what we do with a fire drill. And then every time you as a focal person, when you're doing your audits or you're doing monitoring of or when you just see them doing it wrong, take the time to stay there and train and give them a short training on how to do it better, you know. And so that's what I would say. So at least annually, we should have a training.
Thank you very much, Professor Shade. Just before I go back to Niniola, I think there is an interesting question when we start to look around hygiene and IPC in informal dwellings like slums. We would know that across our continent, several cities, urban and peri-urban areas have shanties or slums, as you might call it, which makes implementing some of this public health and social measures quite difficult. So the question is, how do you handle IPC? And in this context, I'll say, how do you handle implementing public health and social measures in informal dwellings like slums? What are the key considerations for people in quarantine at home, particularly in slum dwellings where crowding is often inevitable? So over to you, Prof.
I think it's very difficult. I think we actually answered this some time ago. It's very difficult. I mean, where it is possible, you take them out of that location and and they quarantine in an isolation center that might be set up for that. Because really, it's difficult for you to talk about self-isolation in a one room where 15 people are staying. The corollary of that is that the person came out of that space. So you either quarantine the whole of them because they are all probably infected anyway because they live together. But technically, it's better to take them out of that location. It's very hard to plan isolation within there. And if you remember during the Ebola, where you had some of these dwellings, it was difficult to quarantine individuals. You just sort of cordoned off that area because it was, I mean, the amount of interaction was such that practically everybody was exposed anyway, and it was hard to say this person is different from this person because they were all living in such close proximity. So I think it will be almost case by case, but as much as possible, take the person out of that environment and keep an eye on all the exposed. I don't have a proper answer, but that's, I think it's a case by case. You'll have to look at that in the house, but it's hard to do proper isolation in those circumstances. So take them out if it's possible and make sure that the others are on isolation, or you isolate all of them together in the same room. I mean, that live together in the same, because they cluster and they're all probably exposed. But take them out is better because you can't monitor them to make sure they don't go out and mix. Thank you. Over.
Thanks so much, Prof. Shade. And Niniola, we will circle back to you now as there's several questions that have been sort of targeted or that you've been tagged in. This says, thanks for a great presentation. You've highlighted the importance of IPC being a part of the RRT, but we still encounter IPC advice or recommendation being disregarded by top management when IPC is not in agreement with sort of the professors or the consultants in most facilities. It's a real struggle and sometimes deflating as an IPC coordinator. So I think from your experience, I'm wondering if some of our participants can get some sort of feedback from you around, sometimes on the job it gets a bit discouraging, but probably feedback or guidance on how to still keep pushing and implementing IPC as part of the rapid response team.
Yeah, thank you for that. It's very challenging when your leadership and authorities don't understand IPC or don't agree with what you want, what you're planning and what you're recommending as the IPC coordinator or focal person. It can be very discouraging, but I think this is where we have to become advocates. We have to make the case. So the question is, how are you approaching the person? How are you giving this advice or these IPC recommendations? Are you coming with evidence? Can you get data? Can you do an audit of your facility and show in numbers and almost like with a report or a paper that, okay, these are the challenges we have. This is the, these are the levels of infection. These are the microorganisms we're getting. These are the challenges we're seeing. It's one thing to come and say we want to do A, B, and C, but it's another thing to say we want to do these things because right now these are the challenges in our facility. So I think coming with data and information that is real time can be helpful. And then also maybe looking at external stakeholders that could support you by advocating for IPC with these consultants or these administrators, engaging maybe either members of the Public Health Institute in your country or looking at how other champions of IPC could come in so that it's not just you alone being the one, making noise that we need to do this, we need to do that, but let there be others that join you in advocating and requesting for these things to be done. It's not easy and there are really no simple answers to this, but we have to keep pushing and we just have to hope that at some point they will come on board. But in the meantime, don't be discouraged. Try and find, even if your management is not on board, try and find colleagues that are on board with you so that you can do IPC, well, to the best of your ability with whatever constraints you have. It may not be perfect, but it will be something. And if you can have, tackle some low-hanging fruit and have some successes and some wins and show that evidence, that will also convince people and get people on your side. So I think those are the things I would recommend for that. Over.
Thanks very much. So colleagues, there are a couple of interesting questions around religious or worship centers. I think that we've got about five of those. I say this, that's why I say sort of brace yourself so that we can give, very, very scientific feedback around IPC or implementing public health and social measures in places of worship. I think I would leave it as like an open-ended sort of question because there are 5 of them and they're all similar. What I will do is we'll start off with Niniola, start off with Lee, and then go to Prof, Anna and Lizzie to give their feedback around how we can improve IPC or public health and social measures in places of worship. So Niniola, if you'd like to take a stab at it, and then we move to Prof.
Sure, thank you. So I'll just make a few comments and let the other panelists contribute. But one of the things that we had to do, and are still doing is engaging the religious leaders and associations. There was a lot of resistance, as I'm sure we can all understand, to any IPC measures at all in these places of worship. The main concern was just to reopen and, get people back inside. And some of them started doing the IPC measures just because they had to reopen, and then they stopped. And so it's about ongoing advocacy with these groups of people. It's about continuing to engage their leaders as well. Some of the successes we've seen are things like getting them to reduce the duration of the time that people spend in. So if there's, for example, a church service is normally 4 hours, they cut it to 1.5 hours. Or they have, some people stay outside and some inside to ensure there's physical distancing, universal masking. Telling them not to sing, not to pray, not to do those things wasn't a very realistic approach. And so what we had to do was, and again, this is why IPC is so interesting, because when you take IPC out of the health sector, you have to really get very innovative. We have to be innovative in the health sector because we have a lot of resource limitations, but even outside, when you take it into places like schools and places of worship, you have to look at what is on ground and be as creative as possible to apply those scientific measures in the best way. So I think I'll stop there and just turn it over.
Over to you, Prof. Shade.
Okay, sorry, I wasn't so muted. Thank you. I think Nini has said it. It's a lot of creativity, and it's often negotiated IPC. You may not get the ideal, but what you want to do is, which I found, one, let me say, try to find those who you can talk to, who can talk with them, who are influencers in those areas. So part of that was trying to find out the people within their systems that that were more likely to listen, and pulling them with you into the advocacy. But as Nini said, you couldn't stop them from singing. You could not stop them from holding their programs, but at least they joined in they now have hybrid sessions, even though they really don't like this issue of the virtual services. The other thing that I think has been useful is that despite the fact that a lot of the religious leaders are not for it, we need to keep sending out our message, because members of their congregation, many of them listen to these messages, and many have by choice gone into the virtual platform. So some of the things Nini said, getting some outside, some inside. The other part of it was, please open your windows. Leave the windows wide open, because ventilation is so important, so that at least it will make it less dangerous than when they've got all their when they've got everything locked up, especially those that have air conditioners. So one of the things that was easier for us to get across to some of these people was open the windows, let there be ventilation, have a 50% population. They've all strayed back to where they were before, reduce the number of lectures, services. Those have helped. But what you find in churches, they're all masking, but the minute somebody wants to sing, he removes the mask. So it really negates the whole idea. Somebody wants to talk, they remove the mask. So we've started some of the messages of, don't remove the mask when you're going to talk, move the mic closer to your mouth rather than remove the mask. So it's really more about small wins, trying to get them to do both virtual, hybrid, and reducing the length of time for the services. And it's a lot of hard work. Where you're having really great resistance, find those who are more likely to listen, to whom they may listen, and use their services as well. It's tough, and you win some, you don't win some. And hopefully government directives help. So when the government comes out with those directives, it at least gives you a platform to work with. Thank you.
Anna, Lizzie, if you have anything to contribute.
I can just maybe add just from my side, what we've also done here in South Africa is to try and institute more IPC practices, when people do visit the churches, to go and actually perform hand hygiene, have the screening tool in front as well. But like Prof. Shadai said as well, it's sometimes very difficult. It's a behavior change that we have to ensure it's happening. And I think just being always in the front to show as an example, and then to try and do the best with what you've got, because we know people going to churches want to be there and they want to talk to one another and they want to sing, but we need to try and see what is the best possible actions that we can do to be the safest while they are there. That's all from my side. Thank you.
Thank you, Lizzie. Anything to add? Because it does look like places of worship are quite interesting for us to discuss today. So over to you, Lizzie.
Thank you, Dr. Wande. Good afternoon, everyone. Just to emphasize what Prof. Shade was talking about, the issue of ventilation, it becomes very, very important, especially in minimizing the transmission in these church settings. And also what has worked in other settings is they have shortened the time that they spend in a service, and they split the services like, let's say 2 hours apart, so that those who really feel the urge to physically attend the church can be catered for. Thank you, and over.
Thanks very much. So we'll come back to you, Niniola, now, is around if you can shed more light on risk communication in rapid response team. I must say that at Africa CDC, our RISCOM group also has similar webinars. I think they do that bi-weekly. Please feel free to check on our website if you're interested in risk communication and community engagement. For more information, then I'll hand over to Nini to touch a bit on RISCOMs.
Thank you, and that's a great question. So risk communication is really focused on, working outside of the health sector. So they are the ones going into the marketplaces, engaging with community leaders, religious leaders, ensuring that people are getting their questions answered. So when you see things like public service announcements, when you hear things on radio, when you see posters and signage, when you see, all these things that are public facing messages, for example, about COVID-19, that is risk communications. As well, there's a bit of updating the general public on the status of the outbreak or the epidemic, how far it's going, what's happening in the country, the numbers that are coming out every day, every week, all of that is risk communications. So it's the reason IPC plays a role in that is because we've had situations here in Nigeria where an official government agency was communicating with their stakeholders about COVID-19, and they were communicating information that was incorrect in terms of how to wear a mask, and other, prevention strategies that can happen in the community. And so it's very important that as IPC experts and professionals, you're working closely and hand in hand with those that are doing risk communication. So I'm happy to hear that the Africa CDC has a webinar series. I think please let's try and plug into that and get as much information as possible so that we can also, we don't need to be risk communications experts, but we do need to understand what they do so we can support them in terms of IPC. Over.
Thank you very much. Prof, I'm going to throw this question at you. Actually, there are about 2 of them. It's around environmental disinfection. And I think in summary is around spraying disinfectants on people around. So the question is, what is the data or evidence to support this? I ask you because I know that at some point we already have it in our curriculum and we're going to be discussing it. And of course, we've had Prof. Shine from ICAN discuss this in several of the other webinars. So it's around, the question is, ideally, environmental disinfection should focus on fomites, that's door handles or inanimate objects. I think the question is, or the feedback is what is our stance on it? What is the feedback that we can give to the people around disinfecting non-healthcare settings and spraying chlorine disinfectant?
Thank you very much. I think we've discussed this extensively. Let me just say straight up that there's no value, and it's also dangerous, and we have shown that with the papers to show that it is dangerous to spray people with chlorine. And there's really no science behind that. The virus is coming from inside your respiratory tract. And so when you spray the skin, the person is still carrying the virus out, and he's going to come out from his respiratory tract. So what's the benefit of spraying the skin? None at all. And there are a lot more things that can go wrong. And we know that from what happened during Ebola, especially in Sierra Leone, there are a lot of respiratory diseases because of chlorine spraying amongst those who were doing it quite a lot. So I think it's important to know that it doesn't really improve the infection control that we need to do. So that's one. Two, even the environment, when you just spray the environment, you get the whole place wet. But the places you really need to focus on are surfaces, especially horizontal surfaces. And we know that just, clean it and wipe it. Wipe it will be fine, not just spraying and leaving the liquid all over the place. It really doesn't have a place, or we're trying to discourage it as much as possible. So there is no place for it. The evidence does not support it. And I think it's important for us to do what is right. However, it seems to have developed a life of its own, with people spraying whole buildings, spraying the walls, I think it gives us a sense that we're doing something. But in terms of the activity, you haven't cleaned before you sprayed. And we know the first thing you do is to clean, then disinfect. So just pouring disinfectant all over the place does not mean you are actually targeting the organisms. They're buried in organic matter. You're not going to adequately sterilize. So it gives a false sense of safety. So we ask that people just, clean the surface and then put your disinfectant and wipe it dry. And then, put it for the contact time and then wipe it off. That is safer. You don't have a wet environment, which organisms like. And to remember that chlorine evaporates. So if you just spray everywhere, after a while it's all water. And that again encourages microorganisms to grow. So our message is, please, there's no value, no real effectiveness that has been shown by all this environmental spraying. And oftentimes you're not even spraying I look at the airport. In Nigeria, we're still spraying people's luggage, and it's just a spray. It doesn't achieve much. The spray, they touch a part of your luggage, it doesn't touch the other part. Your luggage could be as dirty as it is, and someone just sprays disinfectant over it. It's not going to achieve anything either, and it's just going to destroy all our luggage. So I think we need to get away from it. And if you think about it, it's only us in Africa, really, that continue to do, maybe a few other countries, all LMICs that continue to do this spray. And I think we need to reevaluate it. It's not effective. Thank you.
Thank you very much, Prof, for that very, very, very detailed answer. Just to let colleagues know that over the next couple of weeks, at some point, we'll definitely also go back into environmental cleaning, and of course we'll be able to break down some of these things for you to at least have a better grasp. We believe that as we continue to reaffirm the science behind this, it's people like you who would be able to help us on the field and in countries start to implement the right approach for environmental cleaning. A few questions to answer is that yes, there will be certificates of attendance. Once you attend at least, I would like to say 80%, Anna, please correct me if I'm wrong, of the sessions. So that would be, I think, 5 or 4 or 5 sessions you'll be qualified to receive the certificates. I know that Anna will talk a bit about that before we round up. And yes, we will send out all of the training slides. As soon as we compile, it would be in your email that you use to register with this. So Niniola, I know that you did talk about airlines. This question just wants to know if there's a need for us to redesign seating arrangement for physical distancing, and how can we balance that with the load balance, seat reservation, and of course, I'm thinking around the fact that airlines must make money.
Of course.
Yes, I think that's what the person was really trying to say, is that yes, there's the right thing to do, but there's also the business perspective of it. So I'm thinking around how would you address this challenge in your own setting. So over to you, Niniola.
All right, thank you for that. So here in Nigeria, we're not doing seat blocking, as they call it, where, you know, placing people in every other seat. That's not happening currently with domestic flights. But what is happening in place of that is universal masking. So ensuring that everyone is wearing a mask throughout the duration of the flights, ensuring that they don't bring it down. If they do, the hostesses and the airlines, the flight's crew are supposed to, you know, do walkthroughs and make sure everyone's mask is placed properly throughout the flight, since physical distancing cannot be done. Also, one thing to note is that a lot of planes, the newer ones especially, have HEPA filters built into them, which are, you know, particulate filters that help with purifying the air. So if there are any droplets in the air, it helps with that. But the seat blocking thing, it's just really not feasible for many reasons. Apart from the weight balance and issues like that, there's also, as Wande said, the business implication of saying that a flight should go forward with, you know, 50% capacity. And that means that then the passengers that do travel have to almost pay double for their tickets. So it's not really a feasible strategy, which again is why we said when you do IPC, like Prof. Ogunshola said earlier, when you do IPC outside of the health sector, most times you have to just be very creative over. I think Prof wants to say something.
Prof?
Yes, thank you. I just wanted to add to what Nii said. I think the other part of it is also that to remember that airlines also actually do pull in fresh air from outside in addition to, so it's not purely just circulated air. And now for you to travel, you must have a COVID test so that at least within reasonable, more people are probably negative getting on the airlines, although that's not happening at the domestic level. And I suspect that with time, you might not be able to fly anywhere if you're not vaccinated. Because again, so things like doing the test add to the things that don't exist in terms of that, you know, the business case that you can't have blocking of seats. So having people test negative before they get on, and I'm sure we will get to a stage, and for international travel, you're supposed to have tested negative. We may get to the stage where they're saying people should be vaccinated because that's the only way we're going to get closer to normal. So I suspect after a while, we're going to get we're going to have things like people have to be vaccinated to fly so that they don't put people in danger. I suspect, but it might not happen. So I just wanted to add that. So fresh air does come into the airplanes again. So they're actually probably better aerated than other spaces. Then the way the air flows comes from above and flows out at the bottom, helps to localize within some reasonable distance the flow of aerosols, but it's not absolute. And so with that and COVID testing, making sure everybody tests negative by PCR before they fly, adds some level of safety to the flying, but it's not perfect. Thank you.
Thank you very much, Prof. Niniola. So I'll take this question that says that, are there any legislations in any country in Africa to enforce IPC in public places? Yes, I'm happy to speak on that. Specifically for mask wearing, and I would suggest you look on our website for the document around promoting mask wearing during a pandemic. It's a policymaker's guide where we highlight several case studies. For example, I'm quite aware that Togo has a mask wearing mandate, a decree actually, I think is decree number 2000 something, where it's ideally a law, and the only people that were exempt were children under 5 and disabled people. Similarly, South Africa does have a policy that is backed by a regulation, and we also highlight cases from Senegal as well as the Gambia. So indeed, there are several countries who already have legislations to enforce things around wearing face masks, things around physical distancing by keeping the minimum, keeping enclosed places at a very bare minimum capacity. If you'd like to learn more about some of those countries to feed into the work that you're doing, it's available on our website. I think my colleagues might be able to drop the link there for you. So I think we will go to a few other questions, and that is, okay, so I see that Anna is also answering. So if anyone wants to answer this around how can good ventilation in planes or buses, how can we implement good ventilation to prevent respiratory diseases? I know Prof already started to talk a bit about planes and how the clean air is circulated, but Prof, if you want to look at other transportation mechanisms like buses or taxis or combis, or as it might be called in different parts of the continent. So over to you, Prof.
Thank you. I think there are a number of points at which people get infected for transportation. Usually we're all focused on what happens within the bus. A lot of the places where people are mixing is outside while they're, in the waiting areas and so on. And for example, for airlines, they found while we're in the airport, we're probably more danger than when we're on the plane itself. So I think we need to put the things of social distancing, etc., very clearly in the airport. But more importantly, ventilation. Because I can't remember the figures exactly, but when the windows are open, the concentration of ventilation of the aerosols halves in a few minutes, so that you don't have a lot of aerosols in the air. It's diluted. So if you go below the, you don't have a high concentration moving. So taking that into the buses, the most important thing in buses, in cars, and all that is open windows. Now, we could have weather that does not allow for this. Sometimes it's very cold, and so you're using the air conditioner. Please open the windows a little bit so that fresh air still manages to come in. Because what you want is you don't want the concentration to build up within the vehicle. So the most important one is if you can have all your 4 windows or all the windows wide open, minimize the numbers of people within the combi buses. Again, it has been difficult to enforce 50% people, 40%, but let's prevent overcrowding and let's have all the windows open. If all the windows are open, you don't have overcrowding. We should prevent people standing in the middle. Again, I'm talking ideal, or almost ideal, then that will be, I think that's a major thing. And then everybody should be masked in going into the buses, and do the other things. But it will be very difficult to ensure social distancing in all our buses, they're not going to listen to us. But it might be easier to sell opening the windows. It might be easier to enforce not standing in some of the big buses so that you reduce the number of people in the vehicle. I think those are the things I can say right now. And then, of course, wherever they're waiting, if it can be the open air, that's fantastic. Make sure that they're all masked. Have hand hygiene facilities available. I think that will be the best. That is what is achievable for those situations. Thank you.
Thank you very much. I think we are coming to the end of this. And I think this last question, Niniola, if you'd like to take it, is what measures have been or can be put in place to ensure continuous practice of these SOPs as taught by the IPC in different sectors, because they come up after epidemics, but not in between yet. Is a strong argument that we could reduce pandemic. So I think ideally is how do we reinforce this knowledge that we already know and reinforce the practices around this. Over to you, Niniola.
Thank you. Yeah, it's a great question. And really, it comes down to ensuring that we use COVID as an opportunity to strengthen our health systems across the continent by making sure that IPC is not something we only do in an emergency, but that it's something that we sustain between incidents and throughout. It's an everyday thing. And so it really comes down to ensuring that at every level we have advocates for IPC. At national level, at state or provincial or district level, we must have people that are pushing for IPC to be something that is sustained beyond the pandemic, both within the health sector as IPC programs in health facilities for states, for national, but also outside of the health sector. We know that at least here in West Africa, during Ebola, we saw hand washing everywhere. Everyone was so conscious of their hygiene. Different behaviors and practices were being done by people in the community constantly. Then Ebola went and all of the hand washing stations went with it. So we need to think about how to get people to sustain these behaviors beyond the epidemic. It's not easy, but finding champions is something that we found effective here in Nigeria, finding people in those communities, because behavior change is one of the hardest things, and it's really the essence of public health. But when you want people to change their behavior, just putting the thing there, putting a hand washing station in a community is not enough for people to actually do the hand hygiene, right? So you need someone in that community who will be basically almost like an IPC focal person or IPC coordinator, for lack of a better word, to be the champion, to ensure that those things are being done properly. So it comes down to getting more people on board with IPC. And if we all work together, then we can definitely make progress. And I'm happy to say that across the continent, thanks to the efforts of ICAN, Africa, CDC, and other partners, we're seeing a lot more interest in and dissemination of IPC within the health sector and beyond. Over.
Fantastic. Thank you so much, Niniola, for that fantastic and interesting presentation. Thank you to all of the experts who joined me on today's panel discussion. I will just hand over to Anna to let the participants know how they can qualify for the certificate of attendance, what is required from their part. And I look forward to joining everyone again same time next week. Over to you, Anna, and thank you.
Thank you, Dr. Wanda, and thank you for our speakers, Dr. Niola and Chipu, that gave us the information on the status in Africa. For you to qualify for attendance certificate, you need to attend at least 4 out of the 6 sessions, and you need to at least stay on for 60 minutes. That's 60. Students, it got that in the background. It is not a certificate of competence, it's only a certificate of attendance. If you want to have a competency certificate, you'll need to do a proper course, and you can contact us on the level so we can help you with any of that. There is quite a few. I know in Nigeria, Prof. Shade and them are also running some basic IPC and more advanced IPC courses, and we from ICAN run them as well online at the moment. So if you do want to have any certificate of competence in IPC, you can contact us to help you with that. So we want to say thank you very much for everybody. Please keep on attending. And as we said, there will be a French one every week as well, and that will be on a Thursday. And on the English session, we will have Portuguese and Arabic interpretation for all of you. The presentations will be shared by Susan onto your emails, and it will be also posted on the website of Africa CDC and ICAN as well, under our resources, so you will be able to get it there. There's also some recording and live streaming that happens, and that will also be able to be found as well. Susan will be able to send out all of that to all the participants. So we want to just thank all of you and hope to see all of you next week. Thank you and good afternoon.